Hello everyone, welcome to week 3 of our mini course on the history of medicine as part of our University of the Third Age Shared Learning Project, our 1901 postal pensioners. This week we're going to look at diagnosing disease, and this is a huge topic, and I've tried to edit and narrow it down as much as possible. I won't be able to cover everything, there's going to be stuff I don't know, but in the discussions we can sort of play around a bit and think up some more questions. So I'm really trying to give you as simple and as comprehensive an overview of what is really an exceptional time in the history of late Victorian, Edwardian interwar medicine. Great advances are made, but also it's building upon a much older tradition of clinical diagnosis. I'll give it a start now. So our aims for this week might be kind of self-evident, is to gain a better understanding of the different ways in which diseases and conditions were diagnosed in the late 19th, and I should also say early 20th centuries. So something to understand, and is important to understand in this period, is the ways in which medicine and the diagnosis of illnesses and conditions really changed. And it all starts in revolutionary France, as a lot of things in our modern kind of era can be attributed back to, where we sort of see a transition from a model of medicine which really focused on the whole person. So it was a holistic view of medicine. And you can kind of see this where, if you're familiar at all with the idea of the four humours, that idea that, you need to consider the balance of the humours within the whole person and treat them all, accordingly. And so really, it was very much guided by, the patients reporting what their symptoms were, and the doctors being guided a lot by the patients. What hospital medicine does, and really what modern medicine is like now, it really does focus on local sites of disease, like the broken bone or the abscess or the lung. And this has ramifications not only for how we diagnose disease, but also how we organize disease. So diseases increasingly come to be grouped around, the sites of the body that they affect. So, we'll look at that diseases are like dermatological diseases are grouped together, diseases of the heart and respiratory system are linked together, of the stomach, and so on. So whereas before we had a model of medicine that was very much person-centered, now increasingly it's moving more and more towards the biology of the disease. And in doing that, doctors really take on a fairly more authoritative role as scientific practitioners and looking for these objective signs of disease. So looking at stuff like temperature, heart rate, the color of the urine and stuff like that. And this is, it shows again how the patient is perhaps taking less of an active role in diagnosis, but it also illustrates the new technologies that are arising out of this change in medicine. And one of the most important ones for these is the stethoscope, which increasingly is being used in the opening decades of the 19th century, again originating from France, to diagnose certain respiratory conditions. So, being able to listen to the inner workings of the body, through these new diagnostic technologies is a really important new dimension to physical diagnosis and the physical examination. Another important aspect of hospital medicine is autopsies or post-mortem examinations. And these were used again to think about local sites of disease and their relationship with clinical symptoms. So, for example, looking at the lungs to look at how the inflammation or irritation of tissue, what relationship that may have with, coughing, or, what relationship that the changes to the kidney would have to, stomach pain or pelvic pain in patients. And importantly, the autopsies and post-mortem examinations are often also used to either verify or not verify the presence or absence of a disease or condition. So it's kind of there a lot of the time to confirm a diagnosis. So, you have the physical exam, you have the clinical observation of the patient, and then you use the autopsy to verify your diagnosis. And so much of this kind of looking inwards into the body is, like I've mentioned in the previous slide, really linked to these technological advances. This man here is Joseph Jackson Lister, who was a Quaker wine merchant and like a lot of Quakers, really into his science basically and his knickknacks. I include him here because if anyone's familiar with Joseph Lister, who is the surgeon who, at least in popular history or popular understandings of history, pioneered surgical hygiene, Joseph Jackson Lister is actually his father. And what he did is he created a new type of achromatic lens. Don't ask me particularly what that means, but essentially what it means is it enhanced visibility of very, very small things, essentially. So he actually does work into mammalian blood cells. And so doctors are increasingly in medical universities being trained in microscopy, being trained to use these new technologies to make diagnoses as a part of their sort of arsenal or toolkit. And then being trained to use these microscopes in pathology departments that are increasingly popping up in the medical universities from around the mid to late 19th century onwards. Because a lot of the time as well, what's happening is universities are increasingly linked to hospitals. So, students will be going and making rounds on the wards, much like they would do today. And the pathology department would both teach students pathology and how to use the microscope, but they'd also be running tests for the doctors on the wards as well. So they'd be running tests on, as you can see here, things like urine, blood, and body tissue as well. And then from the 1860s onwards, but really growing from the 1880s, these departments begin to study and diagnose and look at disease organisms too. So, disease microbes and germs. So they do a lot. Pathology in this period is kind of a mushrooming discipline that sort of that takes a lot with it. And I'm going to talk a bit here about post-mortem diagnosis because, on this project we are looking at, the causes of death for your pensioners. So end-of-life care is important. A lot of your pensioners wouldn't have had postmortems done on them because their deaths wouldn't have necessarily been suspicious, but some of you might have, and so I felt it was important to cover this. So with post-mortem diagnosis, there are a number of really important changes in the 19th century as post-mortem, a sort of anatomical education in universities is increasingly seen as a critical central part of a medical student's education. I'm sure many of you are aware of the Burke and Hare scandal, the body snatchers operating in Edinburgh in this period, because these teaching hospitals were so hungry for cadavers for their students to operate on and learn the basics from. And there were other things as well. So talking about like new techniques for staining, for example, so for making sections of the brain in particular, this is something we see in this period. The injection of dyes as well to see, for example, the nerves, the nerves of the nerve pathways of the brain, and other organs being illustrated through special dyes. And again, microscopes for studying the cellular changes of disease, so studying processes like inflammation. Then we also see in larger hospitals the growth of dissection rooms, and again, like I said, the universities were really tied to these hospitals. But there's also legal changes that incentivize post-mortem diagnoses in cases of suspicious death. And this was obviously, as family historians, you'll know this, the introduction of civil registration from the 1830s to 1860s across Britain, what was then Britain, meant that all deaths had to be certified, and that included suspicious deaths. And although coroners have been around since like the 12th century, there's a long tradition of them. The Coroners Act of 1887 did establish finally a statutory obligation for coroners to hold an inquiry in case the person had died, quote, either a violent or unnatural death, or a death the cause of which is unknown. Okay, the next two slides are going to contain pictures of pathological material, but I think they're important for sort of illustrating and bringing together some of these big themes and changes I've talked about. In terms of looking at post-mortem diagnosis in action, as it were, I've spent the last few days watching The Terror, which is a historical drama based on the doomed Franklin expedition in the 1840s to find the Northwest Passage. And so much of this series is actually really about the history of medicine, because a lot of the reasons, it's been speculated by historians that one of the reasons the expedition failed and, no one survived is, a combination of medical causes like scurvy, botulism, lead poisoning, etc. And this is from the first episode where the anatomist on board, an anatomist called Harry Goodsir, who was a Scottish anatomist alongside his brother, and actually did some really important stuff with regards to pathology in this period. They have a young crew member who dies, and he performs a diagnosis, a post-mortem to try and determine whether this is scurvy. And you can see here he's cutting out the liver here, and he examines it in the light, and he determines that from the inspection of this liver that this isn't a case of scurvy that they're seeing. If you're interested in this further, I'd really recommend a place that I think brings together a lot of this stuff. So it brings together the stuff about medical education and the importance of these new pathological techniques is the Surgeons' Hall in Edinburgh, which has its own pathology museum. And you can see here, on the left, they've got a recreation of a kind of an anatomy lecture theatre, and they have a projection of a body here, and they have someone kind of giving a lecture. And I think it's actually, like, I've been to a lot of medical museums, and I think it's the place that actually does the best job of illustrating, what this experience would have been like and why it was so important. And you can see here, these are some of the pathological specimens housed at the Surgeons' Hall. And again, it really shows you how, like, students would be inspecting these pathological specimens and they would be studying them quite in depth. And it would teach them how to make, these kind of post-mortem diagnoses, based upon what they had seen in these glass jars. Okay, so for those of you who've looked away because of the gross pathology bit, it's safe to look back now. Another really important diagnostic, I don't like to use the word innovation, change in this period is the development of X-rays, which are actually used a lot of the time therapeutically. So a lot of radiotherapy is happening in this period, but it's obviously also used diagnostically in much the same way we would imagine it today. Again, like much of what we see in this period, a lot of the change sort of emerges first in Scotland. So, this kind of anatomical tradition in the university, a lot of that emerges from the period of like the Scottish Enlightenment in the medical schools of Glasgow and Edinburgh. And again, with X-rays, the first radiology department did open at Glasgow Royal Infirmary in 1896. But really, it was the interwar period that witnessed quite a substantive growth and sort of routine, the growth of routine X-ray diagnosis in conditions like pulmonary TB. So again, looking for lesions, cancer, arthritis. So again, you're not having to wait till the person dies to like cut open and see the typical like TB tubercular lesions on the lungs or anywhere else. You're able to see on a living subject, which obviously has multiple benefits. There's also the bacteriological revolution, so the study of disease organisms. So I'm talking here about disease microbes, but I guess you would also include in this like yeasts and molds as well. So the study of disease microbes brought with it new ways of microscopically testing for infectious diseases. So perhaps the most important and prolific one of these is the sputum test for TB. You can see a slide of that here, what the bacteria look like under the microscope. They're these little rod-shaped bacteria. But then we also get, in 1896, the Weidel, I've never known how to pronounce it, test for typhoid. And then very importantly, the Wassermann test for syphilis in 1906. It's just important to say that just because all these tests were being introduced, it didn't necessarily mean that doctors were welcoming them with open arms. There's a fair degree of skepticism amongst a lot of them about how effective the tests were, and a lot of them would have had enough clinical experience to know, for example, through things like, you know, the stethoscope and examining the patient physically, a lot of them would have felt comfortable enough to say that's definitely TB without having to send off for a test. So, you know, just to say that just because these tests are being introduced around this time, you know, it doesn't necessarily mean there's a great big revolutionary change in how in diagnosis. I thought here I'd just have a quick segue into the role the post office played in pathological testing. So a large number of clinical laboratories in this period offered diagnostic tests for diseases like TB and later like syphilis. You know, and especially because, you know, as we talked about the other week when we looked at medical officers of health, you know, a lot of the time these medical officers of health would have been dealing with these outbreaks and they would have wanted confirmation of the disease they were dealing with. So they would have sent off to these laboratories if they didn't have their own sort of equipment or their own or the kind of skill they needed. They would send off for these specimens to these big London primarily based laboratories like the Lister Institute and the Clinical Research Association for testing things. But the issue there is obviously how do you move that stuff? So they were sent regularly via the letter or the parcel post, sometimes by the patients themselves. So the patients would send the things to their doctor, or the doctors would send off to the big medical laboratories. And also I've found instances of post-mortem diagnosis for farmers. So if a farmer had a chicken that died, you would send off the chicken to a vet, and you would send it via the post. And this actually was illegal technically because there was a thing called the Post Office Protection Act, which talked about it was, you know, it was made statutory that you couldn't send things that would be dangerous or injurious to postal workers. But eventually the post office did make arrangements for pathological specimens to be sent via the post, but there were really frequent disagreements between the post office management, clinical laboratories and the post office unions. And a lot of this centered on the fact that there were fairly frequent breakages. So you can imagine if you have a glass tube of spit or of urine, for example, and it's traveling along a postal system that is becoming more and more mechanized. So here I have a small detail of the post office railway, and this was a small underground railway, which you can have when the postal museum opens again, you can pay to ride on. Now it's not used anymore, but you can experience what it was like being a letter shuttled along this underground network which connected sort of the main postal hubs and sorting offices in London. And as you might imagine, when this stuff is being driven along in a little motorized car and it's being dropped in a big elevator chute and a bag chute, and it's being handled by, you know, overstressed workers who are busy sorting out a million things an hour, you can imagine breakages are not going to be uncommon. So a lot of the time we see representations made by workers and by the unions complaining, you know, this sorter had blood all over his hands and he saw that this was a test for something like syphilis, or this was a test for something like diphtheria. But at the same time, the laboratories would argue back that actually it's not that dangerous, you don't have to worry. And if anyone is interested in reading more about the history of this, I published an article about this that's on the project library, which people can feel free to go and read. But I just thought it was sort of a nice way of sort of bringing the post office back into this lecture. And I also wanted to bring out some further research we've been doing, and this is a case that was brought to my attention by Holly Marley, our PhD student, who's looking at the history of the Post Office Medical Service, because we're still doing a lot of work on what exactly kind of diagnoses were being made by Post Office medical officers in this period. But I also want to bring to light the fact that, you know, diagnosis was not, and still isn't, you know, a simple process. It's not like we as patients, or even patients in the past, like passively accepted what doctors said was wrong with them. And this is a really interesting case of a telegraphist called Mr. Billingshurst, who had time off due to what he said was typhoid. But the post office medical officer basically didn't necessarily believe him and kept on asking him to come to work to prove, you know, that he was unwell, or to give him a new certificate to justify his absence. And, you know, there was strong feeling here, as you can see. An MP made a point to talk about this in Parliament. So this is what this text comes from. It comes from a précis of a Parliament, a session in the House of Commons. You can see it's clear that Mr. Billingshurst and his family found, you know, this constant scrutiny of his state of health quite invasive. So it talks about the summons being injudicious, harassing, and unprofessional. And they had no reason to believe they were suffering typhoid fever. And then here it says, you know, the MP is talking about that it was quite possible for a medical man, however experienced, to make occasional mistakes from the medical supervision of such a large number of men as were employed in the post office was entrusted to him. So, you know, diagnosis wasn't then, still isn't, a perfect science. And again, I'm talking about here between malingering and medical abuse, because obviously what's happening in the case of this medical officer is he suspects Billingshurst of faking being sick, essentially. Victorians called it malingering, and they were so highly suspicious of it. They were just constantly worried about it. You know, but then obviously on one hand they see this as potential malingering, but then I feel there's a real sense in which, you know, the diagnostic process is seen by Mr. Billingshurst and his family and friends as an example of medical abuse. They wouldn't have called it medical abuse, but, you know, they definitely see it as a case of the doctor overexerting his authority over the patient. Okay, so there's been a bit of a whistle-stop tour, but now I'm going to talk a bit about the task, the research task I want you to do for this week. So, using the resources listed in the syllabus for this week and the resources we've explored in the previous week, I want you to try and determine what kinds of tests and or exams would have been administered to diagnose your pensioner, either pre or post-mortem. And often it would have been the same. It would have been both a pre and post-mortem diagnosis. You know, so again, like I said, you look at the clinical symptoms, you maybe run some tests. Then when the patient dies, if you're, you know, if it's a suspicious death or a death where you're unsure, you would run a post-mortem. And these are just some ideas for things you might be able to explore. It's just starting off points. As usual, feel free to go down research rabbit holes. So, for example, thinking about what kinds of tools your doctor would have needed to make their diagnosis. Would they have needed a microscope or a stethoscope? A lot of the time they might not have needed it all. They might have just been able to look at a patient and be like, you know, I have seen cases like this a million times before. I know this is pneumonia, you know. So a lot of the texts that I put in the syllabus, they might not necessarily say you need all this newfangled technology. They might just say, look at how their eyes are glazed, or look at, like, hear how they're breathing, for example. And again, and this links onto the second question, is would the doctor have primarily relied on the outward symptoms of a disease, like, you know, how coughing, so listening to the kind of congestion of the lungs, or rash on the skin, for example, Or would they have had to investigate the inner workings of the body? So would they have had to undertake blood tests? Would they have had to send off to a laboratory asking them, you know, can you confirm this is a case of typhoid for me, for example? And then I want you to kind of think a bit, sort of like put yourself in the shoes of Mr. Billingshurst or Billingshurst family and your pensioner. And I want you, and this is a bit more of a much open-ended, much more exploratory question, which is thinking about how your pensioner or their family might have felt during the diagnostic process. You know, do you think they would have found the process invasive? You know, what kind of tests were being administered for this, and you know, what would their levels of comfort have been, and would they have been worried about the outcome? You know, that's especially in cases where it wouldn't have necessarily been clear that, you know, it could have been a case of pneumonia, or it could have been a case of pulmonary TB, for example. You know, so yeah, as usual, just sort of go forth, look at the material, come up with questions of your own. You know, and yeah, thank you so much for listening. I'm really looking forward to discussing this week. I think it's going to be a really interesting week. And yes, I hope you enjoy this little cartoon as well, which I liked very much. And I think kind of encapsulates, you know, how ideally I think doctors would like our bodies to be and to behave, but they don't, unfortunately, either today or in the past. Right, I'm going to end there. Thank you so much, and I'll see you all soon.